We're not able to make a comparison. You're talking about an emerging technology versus one that's 15 years mature. And so my tack here is not to trash MRI, but to see how the two imaging modalities can be used together. Maybe the audience is completely familiar with the fact that the microultrasound operates at 29 megahertz. That increases the or decreases the size of structures that you could adequately image down to 70 microns. This is a commercially available device for the US, North America, Europe, and Canada. You can do it transperineally, transrectally, and with MRI fusion. It does provide superior imaging details on the right sized prostate. Here's the ejaculatory ducts, the peripheral zone, the urethra, et cetera, et cetera. What blew my mind in some of my first go-arounds was the ability to actually see the needle tracks of prior biopsies. It's not often, though, that you would see three of them arrayed perfectly in a single plane like that, but nearly every man who's previously had a prostate biopsy, you would see the sequelae of the previous biopsy, and if it was negative, you could avoid that spot, for example. You've heard a little bit about the Primus classification, designed to be somewhat analogous to the PIRADS classification. And this is just the initial go-around. And as you know, there's already PIRADS version 2, and they're talking about PIRADS 3 and other modifications to it. The money shots are here. This would be a Primus 3 lesion. It's a little bit different and not quite as homogeneous as the rest of the peripheral zone. These are sort of the signature Primus 4 lesions. Shown here, the starry sky, you saw a little bit of that earlier, and this hypoechoic, sharply demarcated lesion, and this would be a very heterogeneous Primus 5 lesion. It's recognized. This is going to require training on the part of urologists, just like it took training to learn how to even follow what your radiologist was telling you about MRI. And so I compliment ExactView in having this online training system. You can see the steps here, and it's very, very valuable. It's been studied in a cohort of patients, and after somewhere between 30 and 40 cases, an individual's positive predictive value and whatnot seems to stabilize. So there's probably a learning curve of 30 or 40 cases like that. As I said, this can be done either transrectally, you see a needle coming in there, or transperineally. You could do MRI cognitive assist, where you've just localized the location of the MRI suspicious lesion there, and you could see it. Or you could place a dot and just put your ultrasound probe in and move it from right to left, scanning, and you can see in the little homunculus where the MRI lesion is. You're right, that guides you to then look and see if there's a microultrasound lesion once you've co-registered the two studies, and then you could do another form of a cognitive assist biopsy. I'll present a little bit of data. This is sort of something you've seen a million times with the PIRADS classification, showing that there's a higher probability of aggressive cancer in your 5s, less so than your 4s and your 3s. It was designed to be analogous, and it is analogous to the Primus classifications. Here's a meta-analysis of microultrasound guided biopsies versus systematic biopsies, showing this one outlier here, no statistically significant difference in the detection of aggressive cancer, but less detection of non-aggressive cancer, which is a laudable goal, certainly for MRI imaging as well. I like this slide, and I'm not going to spend a lot of time talking through it, but you want to find the dark blue cancers. And in sequence, if you want to find the most number of dark blue aggressive cancers in prostate, you actually need to do MRI-targeted biopsies, microultrasound-targeted biopsies, and systematic biopsies. They're complementary in finding clinically aggressive cancer right now. There are a number of studies of microultrasound in men with negative MRI. So there's a 27% clinically significant cancer rate. Now that seems to be a little bit high, you know, among good radiologists. Gee, MRI's negative predictive value should be 85 to 90%. So, okay, you might say that's a little bit suspect. But there's a lot of different institutional reports here. I guess it's, what is that, 15 or 13 clinically significant cancers. This one had 15 clinically significant cancers. Here, there was a higher discovery of clinically significant cancers than, in this case, the Artemis fusion biopsy. I saw this paper yesterday. This looks at the microUS system for MRI targeted biopsy, and this showed identical pickup between the microultrasound targeted and the microUS MRI targeted biopsies. A study done at 11 institutions, you've already heard about it, designed as a non-inferiority study, was non-inferior, and through some statistical manipulation above my pay grade, you could say it was even significant, but nobody would say that it is. You have to do a prospective study to one day prove that. Since we're at a focal therapy meeting, I thought it would be interesting to talk about the ability of these imaging modalities as reported to identify what's referred to as the index lesion when you've had a radical prostatectomy in these patients. And you can actually see neither of them were pretty good, that good, right? Sensitivity is only 65 and 77% respectively. And this study, again, just came out a week or so ago, and this one I think was from Ash Tawari's group. Again, the ability of either modality, when you look at radical prostatectomies, to find the index lesion wasn't that good. And has already pointed out, where did microultrasound miss? Those were in the anterior lesions in your bigger prostates. So the technology is developing. Now you could see a 6 to 8 centimeter AP diameter and still get adequate imaging. But it's an iterative process, and the probe and the technology has improved over the last 3 years or so. This has been in the guidelines since last year, and I imagine it'll remain in the guidelines. And the study that's going on now is a blinded randomized comparison of microultrasound versus MRI called the Optimum study. It's going to end up to be 3 arms. One arm, will get only microultrasound and microultrasound targeted biopsies. One arm will have only MRI imaging with systematic and targeted biopsies. And this middle group will be the blinded group where you will be blinded to the results of the MRI. The patient will first have his microultrasound targeted biopsies, then unblinded to the MRI, and then have your MRI targeted biopsies plus systematic biopsies. And this has been recruiting since earlier this year, and hopefully it'll be reported soon. So in summary, I would say microultrasound may significantly improve prostate biopsy. It allows real-time targeted biopsy, probably has a similar diagnostic accuracy, probably has a lower cost. It reverts the diagnostic pathway entirely back to the urologist. But I'm not saying we're not going to use MRI. It may be your first pass should not be an MRI, but we'll see over time. And the early data are encouraging, but of course we must await the Optimum study. So thank you very much. Appreciate it.